Lakerman.
I'm Carla Pecoraro.
And I'm Anne Woolfield, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things O&G. Welcome to our second episode on preterm labour. Last week we covered the background, etiology and risk factors for preterm birth, and today we'll talk about diagnosis and management.
In case you missed last week's episode, here's a quick recap. Preterm labour is defined as birth before 37 weeks, but after 20 weeks gestation. It occurs in 8.1% of pregnancies in Australia and is the leading cause of neonatal morbidity and mortality worldwide. There are 4 main pathogenic pathways: hormonal changes, infection, hemorrhage, and uterine distension that lead to one final common pathway, which causes release of cytokines and prostaglandins that trigger labour. And there are many risk factors for preterm birth, although most women who have a preterm birth actually don't have any of these risk factors.
All right, let's kick off this episode with a case. So you are working in the maternity assessment unit and you're asked to see Katie. Katie is a 30-year-old G2P1 presenting at 29 weeks gestation with intermittent abdominal pain and tightenings. What is the best way to approach seeing Katie?
First of all, we'll start by taking a good history. I like to start by asking Katie a few questions about her pain and tightenings. When did these contractions start? How long do they last for? How often is she getting them? Are they constant? Is she getting a break? Are they painful, or does she just notice a tightening sensation? I also observe to see if Katie has to stop talking or pause every time she gets a contraction. Next, I like to ask about associated symptoms. Has she had any vaginal loss or bleeding that might suggest PPROM or abruption? Does she have any symptoms of infection like bowel or bladder symptoms or any fevers? Sometimes a UTI or gastroenteritis can present like preterm labour. And sometimes an infection itself can trigger preterm labour. Is there anything that might have precipitated the contractions? For example, recent intercourse or abdominal trauma? And how is the baby doing? Can she feel normal fetal movements? As I'm taking the history, I'm thinking, is she in preterm labour? If so, why? Or is there another cause for her contractions or pain? A thorough medical history is also very helpful, but specifically, what happened in her previous pregnancy? Did she have that baby at term or preterm? And what was the previous mode of delivery? I also like to ask for risk factors for preterm labour, and if you listen to our last episode, you should be all over those.
Once we've got a good idea of what Katie has presented with, it's time to do an examination. I always start with general appearance and vital signs. Does Katie look distressed with her tightenings, or is she barely noticing them? Are her obs normal, or is she unstable from sepsis or an abruption? Then we do an abdo-palp and an exam. I check for any palpable contractions and assess their timing, duration, and strength. Is her abdo soft and non-tender in between contractions, or is it woody and tender suggesting abruption? I check the fetal lie and presentation and always measure the symphysis fundal height. This should be a standard part of any antenatal clinical examination in order to prevent missing a diagnosis of fetal growth restriction. We then put on a CTG to assess fetal well-being, which is particularly important for preterm babies who may not tolerate labour as well as our term babies. With extremely preterm babies, I find it quite helpful to use the ultrasound to check for the fetal presentation before I do a spec. This gives me an idea about what to expect on the speculum examination. For example, if I can clearly see the cervix is open and the baby is already descended into the vagina, then I can prepare myself and the woman for what to expect when we go on to do the speculum examination.
Yeah, that's such a good idea. And what are we looking for with the actual speculum exam?
We're looking to see if the cervix is open, which would help us diagnose preterm labour. We're also looking for any evidence of bleeding, ruptured membranes, and we use this opportunity to collect vaginal swabs for GBS and a high vaginal swab for an MCNS, and also a sexually transmitted infection screen if it's indicated. Don't forget a urinalysis, as a UTI can also present like preterm labour. If the cervix is obviously open, we would confirm the dilatation with a VE and initiate management of preterm labour, which we'll go into shortly. If the cervix is closed, then we'd want to have some additional information to help us to determine whether or not Katie is at risk of going into preterm labour.
And then how do you know if the cervix is dilated on spec? Can't you just do a VE instead?
We really want to minimise unnecessary vaginal examinations because theoretically they can increase the risk of preterm labour or infection. If you can see that the cervix is long and closed on speculum, then you don't need a vaginal examination to confirm that. If you do a speculum and you can see bulging membranes or the baby's hair and head, then it's pretty clear that the cervix is dilated. But remember, if the baby is not cephalic or the presenting part is poorly applied, then you won't always get this clear view. It can be a little bit difficult when the cervix looks like a multi-Oz or when the cervix is difficult to visualise. In these circumstances, a gentle VE might be required to check for cervical dilatation.
Right, okay. I guess let's get back to Katie. Remember, Katie is our 30-year-old G2P1 and she's 29 weeks gestation. She's presented with contractions. Her contractions started an hour ago. They occur every 2 to 3 minutes and they're lasting about 20 to 30 seconds, and she looks very uncomfortable. She's had no PV loss or bleeding and her baby is moving normally. There are no signs or symptoms of infection and she has no UTI symptoms. Her previous baby was born 11 months ago at term via a spontaneous vaginal delivery, and she has no significant medical or surgical history. On exam, she has normal obs, she looks uncomfortable, and she's palping 2 to 3 in 10, and they last 30 seconds. The baby is cephalic, and the CTG is normal. On spec, the cervix is long and closed. Great, so she's not in preterm labour. She can go home. Woohoo!
Not exactly. So we've ruled out active preterm labour, but Katie might still be at risk of preterm birth, and we need to determine how likely that is. If Katie is at low risk of preterm labour, then she might be able to safely go home once her tightenings settle. But if Katie is at increased risk of preterm labour, then we should really be admitting her and managing her appropriately.
So how do we know if Katie is having threatened preterm labour then? Are there any tests that can just tell us?
All right, it's time to talk diagnostic tests again.
Woohoo!
Clinical history and examination alone are pretty poor at predicting who's going to go into preterm labour or not. About 50% of patients who present with symptoms of preterm labour will actually go on to give birth at term. What we really want is an accurate diagnostic test that can tell us exactly who's going into preterm labour and who isn't. Unfortunately, we don't have that. What we do have are a few screening tests that can help us predict this. These are the fetal fibronectin, actin partus, partus shore, and the transvaginal ultrasound for cervical length.
Excellent. Tell me everything I need to know. Talk me through the fetal fibronectin test. What is it and how does it work?
So fetal fibronectin was identified in 1988, incidentally the same year that I was born. A truly momentous year. Fetal fibronectin
so old now.
I know I'm giving away my age. This is terrible.
Yeah, that's confident. I thought you were 21.
Forever. So fetal fibronectin is an extracellular matrix glycoprotein that exists between the chorion and the decidua, and it basically helps the fetal membrane stick to the uterus, kind of like a glue. Now, it's not normally present in cervicovaginal secretions, so when we are able to detect fetal fibronectin, it suggests that there has been some kind of disruption between the chorion and the decidua, which can occur in preterm labour. It's also important to know that fetal fibronectin can be found in the cervicovaginal secretions in a few situations. Firstly, before fusion of the membranes below 21 weeks. Secondly, after 35 weeks when the interface starts to break down naturally. And thirdly, when there is a disruption of this interface, like in the case of preterm labour. This is why we don't recommend a fetal fibronectin before 22 weeks or after 35 weeks, because it can be normal to get a positive result.
These numbers I need to write down because I forget it every single time. Don't do it before 22 weeks or after 35 weeks. That is the recommendation. I guess, what do we need to know about actually collecting the fetal fibronectin? I remember with our diagnostic tests for PROM, there were these kinds of rules about where to collect them from and how long to swab for. What are the rules for the fetal fibronectin test?
So for fetal fibronectin, firstly, don't use lube. Lubricant can interfere with the fetal fibronectin result and cause a false negative. Instead, you want to run some warm water over the speculum and rely on the vagina's natural lubrication. It's also important that the fetal fibronectin is collected before collecting any other vaginal swabs or ROM test sampling. Also, do it before a digital vaginal examination or before transvaginal ultrasound, because all of these can lead to false positive results.
Is that just because you're irritating the area and it can release some of that protein that we're looking for?
Yeah, it's thought that cervical manipulation can kind of increase the risk of you getting a false result. So generally anything that's going to poke or prod the cervix or stir things up, you want to try and avoid.
Okay.
So we next collect the sample by swabbing the posterior fornix of the vagina for 10 seconds. We then put the swab in the solute, Mix for 10 seconds, snap off the tip and put the lid on. If you're not going to perform the fetal fibronectin test immediately, then you put a cap on the sample and ensure a tight seal. You have up to 8 hours with the test stored at room temperature to run the sample.
You might do that in some places where you're going to do an ultrasound first before you do fetal fibronectin. So you can collect your test, do a scan, and then do it after. Yep.
Oh, yeah, cool. To run the test, the machine must first be calibrated. You enter the user ID, the cartridge slot and number, and the patient ID. You insert the cassette into the machine and you drop the patient sample. And you drop 200 microliters into the cassette. Then you press test and you stare anxiously at the machine for the next 10 minutes, wondering why you collected the sample in the first place and praying the result is negative so you don't have to organise a transfer to get this patient out.
Every time. The test works by detecting the concentration of fetal fibronectin in cervicovaginal fluids. In normal conditions, fetal fibronectin is undetectable between 22 and 35 weeks. So if you have a positive fetal fibronectin, there's a theoretical increased risk of preterm labour. Now, there are two types of fetal fibronectin tests, a qualitative test and a quantitative test. A qualitative fetal fibronectin will display as simply positive or negative and uses the threshold of 50 nanograms per mil to determine what's positive and what's negative. A quantitative fetal fibronectin result will display as a number representing the actual concentration of fetal fibronectin in nanograms per mil. In a 2013 study, it was shown that quantifying the level of fetal fibronectin in symptomatic women enhances its predictive value over qualitative alone. So we tend to use a quantitative fetal fibronectin instead of a qualitative one.
Are there any situations where I shouldn't use a fetal fibronectin?
It's contraindicated if the cervix is dilated more than 3 centimetres, if there's ruptured membranes. These women are already at high risk of preterm birth. Also, if there's a cyclage in situ or in the presence of soaps, gels, lubricants, or disinfectants. We don't usually use the fetal fibronectin if the patient's had intercourse in the last 24 hours or if she's had any bleeding. This is because the blood and semen can lead to a false positive result. However, a negative result in these situations is still considered valid because the blood or semen will not create a falsely lowered result. So you can still use it after intercourse, bleeding to rule out preterm labour, but you just can't really rely on a positive result in these situations. Some resources state the fetal fibronectin should not be used in the presence of placenta previa, but a review of the literature suggests that placenta previa should not be a contraindication and that it does not affect the concentration of fetal fibronectin.
Okay, just with the intercourse, so I think a lot of the time when we see people with preterm labour, we'll often ask women, oh, have you had intercourse? And it's so that we know whether our fetal fibronectin result will be valid or not. But the woman doesn't know that. Instead, she thinks, oh my God, did I have sex with my partner? And that's why I've gone into preterm labour. So I think it's super important that you just say, don't worry, sex doesn't cause this. I just need to know if it's going to affect my tests or not, because otherwise she's going to think she caused her preterm labour.
Yeah, that's
very
such a good point. So a fetal fibronectin is obtained from a sterile speculum exam without lubrication. The swab goes in the posterior fornix for 10 seconds. We want the quantitative result rather than the qualitative result. False positive results are caused by intercourse, blood, and cervical manipulation, and false negative results are caused by lubricants and disinfectants. Don't run the test if the cervix is already dilated past 3 centimetres, if the membranes are ruptured, or if there's a cyclage in situ. So my fetal fibronectin is going to give me a number, right? A concentration. What do I actually do with this result, Mel?
So the fetal fibronectin result is something that causes a lot of confusion. When the fetal fibronectin is negative, so under 50, it's easy. The test can be considered negative and the woman has about a 1% chance of delivering within the next 7 to 14 days. So we can comfortably discharge these patients. Just be aware that, a reading below 10 is, proper negative, but a reading of between 10 and 49 still increases the woman's overall risk of experiencing a preterm birth before 34 weeks to about 8.2%. Therefore, we should be counselling these women to represent if they develop further symptoms of preterm labour and taking them seriously as well. Now, as the fetal fibronectin rises, so does the risk of preterm birth. A fetal fibronectin over 200 is considered positive or high risk, and the threshold at which we would definitely initiate admission, tocolysis, and steroid loading. A fetal fibronectin of 200 to 499 has a 14% chance of delivery within the next 7 days and a 29% chance of delivery within 14 days, a fetal fibronectin greater than 500 has a 38% chance of delivery within 7 days and a 46% chance of delivery within 14 days. So it's pretty clear. Fetal fibronectin under 50, negative. Fetal fibronectin over 200, positive. Now, it's really annoying when we get a result in this grey zone, so anywhere between 50 and 200. So these women have a 0% chance of preterm birth in the next 7 days, but a 7.7 chance of delivery within the next 2 weeks. And these women are considered to be at intermediate risk of preterm birth. Now, the Queensland and South Australia guidelines recommend admission and to consider tocolysis or steroid loading, but not to automatically commence it. This is because most babies with a fetal fibronectin of 500 to 199 won't deliver within the next 7 days, which is when the benefit of the steroids is greatest. So you can see with these numbers that the real value in the fetal fibronectin lies in its negative predictive value. That is, ruling out preterm labour and preventing those women from having unnecessary admissions and treatment. A negative result has a 99.5% negative predictive value for delivery within the next 7 to 14 days. A positive test is less helpful, with only 14 to 28% of women who test positive actually going into preterm labour in the next week. So you can see, with using fetal fibronectin alone, we will still be overtreating some women who won't go into preterm labour. There's actually a really good table taken from Abbott's study in 2013 that has the values of fetal fibronectin and their positive predictive values. And that's often what you'll find on the little cards that you get near the fetal fibronectin machine that tell you what the risks are with the result. So we'll put that up on our Insta.
Okay, excellent. If I have a patient who presents in threatened preterm labour and have a negative fetal fibronectin, then I can be pretty confident that she's not going to deliver in the next week, and I can safely discharge her home. And if I've got a positive fetal fibronectin over 200, I should initiate treatment. But I'm probably still going to be overtreating some women. What do I do with the women with an intermediate risk of 50 to 199? Is there anything we can do to improve the positive predictive value of this fetal fibronectin number?
So you can use a transvaginal cervical length measurement in conjunction with a fetal fibronectin to improve the positive predictive value. Depending on where you work, a transvaginal cervical length may actually be the first test you do to help stratify those at risk of preterm births, rather than things like a fetal fibronectin or an actin pietis. A long cervical length, so 30 millimeters or greater, before 34 weeks has a high negative predictive value for preterm birth. A short cervix, less than 30 millimeters before 34 weeks, is predictive of an increased risk of preterm birth. Unfortunately, most hospitals in Australia have limited access to timely transvaginal scanning, and so fetal fibronectin is often used to triage women into high, low, and intermediate risk categories. In South Australia and Victoria, women with a low risk history and an intermediate risk fetal fibronectin would have a transvaginal cervical length performed within 4 hours of presentation. Cervical length was greater than 30 millimeters, they'd be discharged. If it's less than 30 millimeters, then they'd be considered high risk and the patient would be admitted for steroid loading and tocolysis. According to a likelihood ratio from 2008, cervical length greater than 30 millimeters is low risk, whereas 15 millimeters is considered high risk. But note, the actual cutoff for cervical length varies by institution, and it could be 15, 20, 25, 30 millimeters. Refer to your local hospital policy. There's a nice little table of likelihood ratios of preterm birth based on cervical length, and we'll put that up on our Instagram page as well.
Ooh, and I've heard of that thing called the Quip app, where I think you plug in things like the patient's gestation, risk factors, cervical length, and fetal fibronectin. Then it gives you the risk of them going into preterm birth.
Absolutely. So this is quite a helpful little app that is being used more and more. It stands for Quantitative Instrument for the Prediction of Preterm Birth, but we prefer QUIP. It's basically a validated prediction model that uses symptoms, risk factors, transvaginal cervical length, and fetal fibronectin results to predict the risk of spontaneous preterm birth. You can download it on your phone and input all of these parameters quite easily. Now, a risk threshold of 5% in the next 7 days is generally considered to be the cutoff for determining who gets admission and steroids. So far, results have been good, with the app having a 100% sensitivity and negative predictive value, and a 30% positive predictive value for delivery within 7 days for women presenting under 30 weeks, and 20% for women presenting between 30 to 34 weeks. The app is being used routinely in Europe and increasingly in Australia. We love it.
Okay, so we've spoken about the fetal fibronectin and transvaginal cervical length and the QUIP app. What if I'm at a hospital that doesn't have access to either of these? Are there any other tests I can use?
Another commonly used test is the actin partis. This detects phosphorylated insulin-like growth factor beta protein 1, IGFBP1, compared to actin prom, which detects the non-phosphorylated IGFBP1. It's a protein that's made by the cells lining the uterus. When the delivery is imminent, small amounts of this protein leak into the cervix. This is collected by a sterile speculum examination between 24 to 36 weeks by putting a swab at the external os for 15 seconds, then adding it to the solute. Once again, similar to a pregnancy test, once the indicator is added to the solute, the result takes 5 minutes. A positive test is 2 lines, a negative test is 1 line. Overall, it has a high negative predictive value of 100% for birth within the next 48 hours and 92% for birth within the next 7 to 14 days. So women with a negative result can be reassured and discharged home. The positive predictive value is more variable and differs between studies, but patients with a positive result would generally be considered high risk of delivering within 7 days, and the patient should be admitted and treated with steroids and tocolysis. Unlike the fetal fibronectin, the actin partis can be used with lubrication and is not affected by the presence of semen, but you can still get a false positive result in the presence of blood. The positive predictive value is about 20%. The actin partis is significantly cheaper than the fetal fibronectin, and it doesn't require a machine that needs calibration. So it's the test of choice for some Queensland hospitals. Now, my tip is, if you have actin prom and actin partis, the prom packet is blue for waters because you're checking for waters, and the partis packet is purple, so it's the other one.
And prom shrom.
Yeah, prom shrom. That makes sense.
Whatever helps you remember. Now, another less commonly used test is the Partisure. So Partisure tests for placental alpha microglobulin 1, PAMG1, which you might remember is the same protein that's tested for in the Amnisure. Now, I had a look into this. I was thinking, well, hell, can you not just use an Amnisure to also check for preterm labor? But apparently you cannot, because the Partisure test is positive at different concentrations. So you can't just replace it with an Amnisure. Now, the Partisure can be done with or without a speculum examination by placing the swab in the vagina for 30 seconds. The swab is then swilled for 30 seconds in the solute, and the test strip is put into the solute. Once again, similar to a pregnancy test, 2 lines is positive, 1 line is negative. The Partisure can be used from 20 weeks gestation and is not affected by lubrication, cervical manipulation, infection, semen, or trace blood. Active bleeding can cause a false positive, though.
Does that mean if there is any bleeding, you wouldn't do any of these tests?
Generally, a trace amount of bleeding isn't a huge deal. It's more like gross, heavy bleeding.
Okay, that's good to know.
But even then, you're probably worried about the gross, heavy bleeding anyway. So
that's a good point too.
Yeah, but remember, if it's negative, it's only going to cause a false positive, not a false negative. So you can rely on the negative result, but the positive one, you're going to be sad that you did it.
So to summarize so far, we have the qualitative / the quantitative fetal fibronectin collected from the posterior fornix for 10 seconds. We have the transvaginal cervical length with cutoffs ranging from 15 to 30 millimeters. We have the actin partis, which is the phosphorylated IGFBP1, and it's collected from the external os for 15 seconds. And the Partisure, which is PAMG1 collected with a swab in the vagina for 30 seconds, swilled. So, Anne, do we have any idea which of these tests is the best?
Well, there is a systematic review published in 2019 that compared the diagnostic accuracy of the Partisure, the actin partis, and the fetal fibronectin. Unfortunately, the designs of all these studies and the populations that they studied were very different, which meant that the accuracy of the tests could not be fairly compared. This review didn't specifically recommend one test over another, but has mentioned that there are a few trials that are currently ongoing, and so the plan is to include a large number of women, which might help us work out which is the best test. So watch this space.
Okay, so Katie has a positive fetal fibronectin of 500 and a transvaginal cervical length of 13 millimeters. We've diagnosed her with threatened preterm labour. According to the Quip app, her risk of preterm labour within 1 week is 18.7%, and with fetal fibronectin alone, that risk is 38%. What do we do now?
In a nutshell, we need to tell the patient and either admit or transfer her out, chart steroids and tocolysis, and arrange neonatal counselling. The first thing we need to do is let Katie know. I would usually say something like, okay, unfortunately your preterm birth tests have come back as positive. This doesn't mean that you'll definitely go into preterm labour, and most women with a positive test actually won't have a baby in the next week, but it does mean that you're at higher risk of baby coming early, and we need to make some preparations in case that happens. We then arrange admission and consider transferring Katie to a facility that has a NICU that could support her baby if it was to be born early.
Next, we need to start steroid loading. Steroids accelerate fetal lung maturation by stimulating type 1 and type 2 pneumocytes. This allows the lungs to produce more surfactant, which makes it easier for the baby to open its lungs and facilitate gas exchange. Steroids have been shown to reduce respiratory distress syndrome by 34%, reduce intraventricular hemorrhage by 45%, reduce necrotizing enterocolitis by 50%. They also reduce neonatal death, cerebral palsy, and need for mechanical ventilation and neurodevelopmental impairment in those born extremely preterm. We typically use betamethasone, 11.4 milligrams IM every 24 hours for 2 doses, but if it looks like the baby might come sooner than 24 hours, you can consider giving the second dose after 12 hours. The other option is to use 6 milligrams of dexamethasone every 12 hours IM for 4 doses. However, we tend to prefer betamethasone as it leads to less neonatal cystic periventricular leukomalacia, and it causes a larger reduction in respiratory distress syndrome than dexamethasone. Betamethasone also requires fewer injections than dex and has more long-term follow-up data.
Are there any other steroids we can use? Like what about prednisolone or prednisone?
Well, the point of giving the mother steroids is so that they can cross the placenta and act on the baby. Betamethasone and dexamethasone both cross the placenta. Prednisone doesn't cross the placenta, and hydrocortisone is extensively metabolized by placental enzymes. So these drugs are pretty useless when it comes to helping out the baby's lungs.
Okay, and what about timing of steroids?
The optimal timing is when preterm birth is expected or planned within the next 48 hours. We get the best effect from steroids when the delivery occurs within 2 to 7 days after administration. After 7 days, the benefits start to decline.
Can we give more steroids then?
Absolutely. So repeat dosing is indicated when there is a persistent risk of imminent preterm birth if more than 7 days has passed since the first course of antenatal corticosteroids and the gestation is less than 32 plus 6. Ideally, these steroids should be given within 48 hours of the expected delivery, but again, benefit can occur up to 7 days after rescue dosing. Now, if you're just using a single dose regime, you can give a maximum of 3 single repeat doses of steroids or a single repeat course of betamethasone, which is the 2 doses 24 hours apart. Now, according to the ACTORS trial, repeat dosing of corticosteroids reduced the risk of respiratory distress syndrome, severe lung disease, and need for mechanical ventilation or oxygen therapy. Possible harms of repeat dosing include an increased risk of small for gestational age, reduced birth weight, and attention problems. So we really want to be judicious with our use of repeat dosing.
And what gestation should we be giving these steroids at?
The ideal timing for steroid administration is between 22 to 34 plus 6 weeks. Just note the upper and lower limits of steroid loading tend to vary by institution and country. In Australia, steroids are recommended up to 34 plus 6 weeks. In the UK, steroids are recommended up to 35 plus 6, and in the US, steroids are recommended up to 36 plus 6. There's not much point in giving steroids before 22 weeks. There are only a few primitive alveoli at this stage on which the drugs can actually act, so steroids at this gestation are unlikely to improve lung function. At the early limits of viability, we generally have a discussion with the family, the neonatal team, because the steroids may provide some survival benefit, but there's always going to be the risk of major morbidity in survivors. So some families choose not to offer neonatal resuscitation if the baby is born prior to 23 weeks gestation.
And then why is there such a difference of opinion in the upper limit of steroid loading? Seems like a bit of a grey and controversial area, Mel.
So there is a bit of an ongoing debate about whether we should be giving steroids to women at risk of late preterm labour. And by late preterm, I mean between 34 and 36 plus 6 weeks. Now, we know that most preterm births occur in the late preterm period, actually about 8% of all births, in fact. And we also know that these infants have higher morbidities than term infants, like respiratory distress syndrome, hypoglycemia, hypothermia, etc. What's not clear is whether steroids are actually of overall benefit or risk to these infants. Now, the antenatal late preterm steroids, or ALPS trial, was published in 2016 and specifically looked at the effect of steroids on adverse outcomes in late preterm infants. The ALPS trial found that steroids reduced the risk of transient tachypnea of the newborn, didn't change the rates of respiratory distress syndrome or mechanical ventilation, and increased the risk of neonatal hypoglycemia. So basically, it reduced the risk of short-term complications like needing CPAP or high-flow nasal cannulas, but didn't make a more significant difference than that. The concerns that people tend to have with administering late preterm steroids are as follows. Firstly, many women present with symptoms of preterm labour between 34 and 36 plus 6 weeks. Now, most of those women won't actually deliver preterm, but the tests that we have to rule out preterm labour and minimise unnecessary intervention are much less accurate at later gestations. This basically means that many more women in the late preterm period would get steroids than actually need it. Now, we know that there are risks to giving steroids, which include intellectual and behavioural impairment, particularly if the baby isn't born preterm. And the benefits are in reducing TTN, which is a short-term complication with minimal long-term impacts to the baby. So this doesn't really seem to outweigh the risk of long-term harm with steroid use.
And what are these harms you speak of?
Maternal side effects of steroids include transient hyperglycemia, usually more of a problem in our type 1 diabetics, increased white cell count, usually about 30% within 24 hours. These changes return to baseline within 3 days, but it may complicate the diagnosis of infection. Fetal side effects include transient fetal heart rate changes, including reduced variability on day 2 and 3, and Doppler changes. Steroids actually tend to improve our umbilical artery and diastolic flow in 60 to 70% of patients, starting at about 8 hours after the first dose and lasting for 3 days. But that doesn't happen for every baby, and babies where the Dopplers don't improve may actually have worse outcomes. Long-term effects include a possible increased risk of mental and behavioural disorders in children, with a higher risk for children who go on to be born at term.
Okay, so to summarise steroids, they're given from 22 to 34 plus 6 weeks gestation. It can be betamethasone or dexamethasone. Ideally give them within 48 hours of birth, but there is a benefit up to 7 days. If the risk of preterm birth persists after 7 days, you can give a rescue dose of steroids again. The benefits include reduced respiratory distress syndrome, intraventricular hemorrhage, and necrotizing enterocolitis. The risks include high rates of poor school performance and mental or behavioral disorders in children. The side effects can include transient hyperglycemia, leukocytosis, transient fetal heart rate changes, and Doppler changes. It's such a big topic, and I'm sure we'll have a lot of things to cover with our Evidence with Anne segment coming up.
Yeah, I better get writing.
No pressure.
Big coffee time. Let's talk about tocolysis. What's the point and what are our options?
Well, the point of tocolysis is to delay preterm birth until we've got the steroids in. Tocolysis can also be useful to allow time to administer mag-sulf or to transfer the patient out. Typically, we wouldn't give tocolysis beyond the gestation of steroid loading, which in Queensland is 34 weeks and 6 days. And when we do give it, we stop after we've given the steroids. Now, a lot of people often ask, well, why don't you just keep giving tocolysis until term to prevent preterm birth? Which is a pretty decent question at face value. There is a Cochrane review published in 2014 that looked at nifedipine as maintenance therapy, which essentially showed that with ongoing use of nifedipine versus the control group, there were no differences in neonatal mortality or morbidity. So unfortunately, ongoing tocolysis does not seem to be helpful in getting these women to term. There appears to be no benefit beyond 48 hours of tocolysis.
There are quite a few different tocolytics available, and knowledge of these can be very helpful for your exams. By far, the most commonly used tocolytic is nifedipine. Nifedipine is a calcium channel blocker that can also be used as an antihypertensive. The dose is 20 milligrams every 30 minutes for 3 doses as a loading dose, then every 6 hours. Side effects include flushing, tachycardia, and a headache.
And low blood pressure.
Yeah. We typically stop this nifedipine after 48 hours after we've given the steroids. Other tocolytics include beta-2 sympathomimetics like salbutamol, ritidrine or terbutaline, indomethacin, atosabam or magnesium sulphate. In general, some of these have side effects for both mum and baby and not considered first line.
Okay, so let me get this straight. Because Katie is at risk of preterm birth, we want to prepare the baby, so we give steroids to help the baby, and nifedipine to delay the onset of labour enough to get the steroids to work. Why are we bothering with the fetal fibronectin? Why don't we just give everyone who presents with contractions the steroids and the nifedipine?
This is a good question and one we often get asked by the paediatric team, particularly in the context of a baby who was born preterm who didn't get steroids. And certainly, we should be aiming to steroid load all babies born before 30 weeks gestation. The problem is that steroids are not without harm, and the number of women who present in preterm labour who actually go on to have a preterm birth is quite low. So if we were to treat every patient who came in with contractions, we would be overtreating women and exposing some babies unnecessarily to steroids which may have harm, but no benefit. So one of our big issues in obstetrics is predicting who will and who won't go into preterm labour so that we can only treat those babies that will be born early. Things that help us predict those at high risk of preterm birth also help us risk stratify patients who might require admission or even transfer to another facility.
Okay, so we diagnose threatened preterm labour. Then we admit, counsel the patient, give nifedipine and steroid loading, arrange a neonatal review or a tour of the nursery, or transfer it to a tertiary facility and tell the peds team. Is there anything else? I remember in our first episode we spoke about giving antibiotics to improve latency in PPROM. Do we give antibiotics to prolong the pregnancy in preterm labour?
The evidence for this comes from the Oracle 2 trial. You may remember in our episode on PPROM we discussed the Oracle 1 trial, in which provided the evidence for erythromycin in PPROM. In the Oracle 2 trial, it looked at whether erythromycin, amoxicillin, clavulanate, both or placebo improved the outcome for women with threatened preterm labour with intact membranes. Unfortunately, there was no improvement in neonatal outcome or in prolonging the pregnancy. The 7-year follow-up of the Oracle 2 trial also showed that more children whose mothers had erythromycin or coamoxiclav developed cerebral palsy and functional impairment. For these reasons, antibiotics should not be routinely prescribed to women in threatened preterm labour unless they go into active preterm labour.
And I have to remind myself of this every single time. So I think these studies are really important. PPROM, yes, antibiotics. Threatened preterm labour, no antibiotics. So Katie, she gets her steroid loading, her contractions have settled, and her nifedipine has ceased. She goes home, but unfortunately she presents again the next day with more contractions. We take our same approach as before. History, exam, CTG. However, this time when we go to do our spec exam, we see bulging membranes. We do a VE and Katie is 4 centimetres dilated. What do I do now?
So now Katie is in established preterm labour. We need to change our management plan a little bit. We've already given our steroids 2 days ago, so we know we're in that 7-day window and we've optimized our lung maturation, so there's no need to give any more right now. There's not really a role for nifedipine here unless our hospital can't look after babies at 29 weeks, in which case we could consider nifedipine to allow transfer, or if we needed to buy some more time to get the magnesium sulphate to kick in. Just be really careful when transferring women in active labour, especially preterm women. Remember, Katie is a multi, so there's a chance she may deliver quite quickly. So sometimes it might be safer to just manage the labour and delivery at the hospital the patient presents to and get the neonatal team to come to you instead of risking a delivery of a preterm baby who's likely to need some support in an ambulance on the side of the highway. Also remember that nifedipine is much less effective at being a tocolytic when the patient's in active labour. We need to remember to keep that CTG going and also to commence IV antibiotics. If you listened into our Group B strep episode, you might remember that preterm birth is one of the big risk factors for early onset Group B strep disease, and so we give IV benzylpenicillin to reduce the risk of GBS. The other thing we need to do is commence magnesium sulphate.
Magnesium sulphate is used for fetal neuroprotection, and it's been shown to reduce the risk of cerebral palsy by 1.6% and reduce the risk of substantial gross motor dysfunction. The mechanism of action is poorly understood, but it's thought that it stabilizes the cerebral circulation and neuronal membranes, prevents excitation injury, protects against oxidative injury by antioxidant effects, and gives anti-inflammatory effects. The dose is 4 grams in 20 mils of normal saline over 20 minutes, followed by a maintenance dose of 10 grams in 50 mils of normal saline over where it's 1 gram per hour. We get the best effect when magnesium sulphate is given for at least 4 hours within the 6 hours prior to birth, and we typically continue the magnesium sulphate until birth. If it doesn't occur after giving MagSulph and the preterm birth appears imminent, we can continue giving a repeat dose as long as it's been over 6 hours since our last dose, as per the BEAM trial. Now, keep an ear out for another Evidence with Anne episode that I will need to write to discuss all the evidence of magnesium sulphate.
Anne is a busy stat queen.
We've thrown you under the bus.
And when exactly can we give magnesium sulphate?
So none of the randomized trials for MagSulph for neuroprotection included pregnancies under 24 weeks. The NICE guidelines suggest having a discussion with the woman about using MAG between 23 to 24 weeks gestation. MAG is definitely indicated between 24 to 29 plus 6 weeks gestation if birth is anticipated within the next 24 hours. But you can also consider MagSulph for women between 30 weeks and 33 weeks and 6 days. In a meta-analysis stratified by gestational age, benefits of MagSulph were similar for babies below 30 weeks and babies below 32 to 34 weeks, with a very similar number needed to treat of 46 and 56 respectively. Just be aware that most of the data for this meta-analysis came from trials with pregnancies under 32 weeks. So some facilities are more comfortable offering MagSulph only up until 32 weeks instead of the 34-week gestation mark. We are eagerly awaiting the results of the Magenta trial, which is specifically looking at the role of MagSulph for neuroprotection on infants between 30 and 34 weeks. Come on, Carolyn Crowther.
Woohoo! Are there any other side effects to be aware of?
We mainly want to watch out for magnesium sulphate toxicity, and we do this by monitoring the respiratory rate, deep tendon reflexes, and urine output. Magnesium sulphate toxicity can lead to ECG changes, loss of deep tendon reflexes, respiratory paralysis, CNS depression, and even cardiac arrest, which is why monitoring the patient is so important. We would want to stop the magnesium sulphate infusion if we had any changes suggestive of toxicity, like a reduced respiratory rate, usually less than 12, absent deep tendon reflexes, or a reduced urinary output. More common side effects include facial flushing, hypotension, and reduced variability on the CTG.
Yeah, unfortunately, it makes women feel incredibly rubbish, which is one of the downsides of giving MagSulph. Also, make sure you look out for the contraindications to MagSulph, most notably cardiac conduction defects like heart block or myocardial compromise, obviously if they're got hypermagnesemia, and myasthenia gravis. We also tend to reduce the dose in patients with renal dysfunction, as magnesium sulphate is eliminated by the kidneys, so these patients are at a higher risk of MAG toxicity. Make sure you check your guideline, but typically we give the same loading dose, but either don't run the MagSulph infusion or run it at a lower rate.
Okay, so MagSulph is used for fetal neuroprotection in babies from 24 weeks to 32, maybe 34 weeks. It works best if given within 4 hours of birth and can be continued for up to 24 hours or until the baby is delivered. MagSulph reduces the risk of cerebral palsy and gross motor dysfunction. It's given as a 4-gram loading dose and then at 1 gram per hour. It's contraindicated with myasthenia gravis and myocardial compromise. And we want to watch out for toxicity by monitoring the resp rate, deep tendon reflexes, and urine output. Is there anything else we need to consider with preterm birth?
Absolutely. So in terms of delivering the baby, we need to be really careful with our instrumental births. We definitely should not use a vacuum under 34 weeks because it increases the risk of subgaleal hemorrhage. Forceps are a better option, but they've also got limited use simply because of their size relative to the fetal head. We also want to avoid FSC and fetal blood sampling under 34 weeks gestation.
We also absolutely can do CTG monitoring in preterm babies, but the interpretation can be difficult. I think where most people struggle here is that it can be relatively common to have a higher baseline, reduced variability, and a lack of accelerations in a preterm CTG, particularly when we've given steroids or magnesium sulphate. This means that we can never really classify a preterm CPG as normal. But decelerations are decelerations, and these are abnormal no matter what. So if you have a baby with a bradycardia or prolonged complicated variable decelerations, then this is still indicative of fetal distress, and you should look at managing that. I think one of the other reasons we often get a bit of pushback to doing CTGs in our premature babies is that it's actually really hard. So these little babies move around a lot, and it often needs a midwife to literally sit there holding the CTG, chasing that baby around, which is very difficult. And we can't use a fetal scalp clip, so we're a bit limited by that as well. We hear you, midwives. We're sorry.
At the time of delivery, you got to be really gentle. These preterm babies are very fragile, and they can be definitely at risk of injury at the time of birth, either by vaginal delivery or cesarean section. Ideally, try and deliver the baby with membranes intact if you can, or minimize the manipulation you do with these babies.
Preterm babies are also really bad at keeping their own body temperature warm, so we try and deliver babies under 30 weeks straight into a plastic bag. Now, this sounds terrible, but is actually really good for reducing their heat loss. It's kind of like a little plastic baby blanket. We also definitely want to do delayed cord clamping. These babies definitely benefit from delayed cord clamping, at least for 30 seconds or until the cord stops pulsing. But typically the neonatal team will help guide you as to when to stop the delayed cord clamping. So if the bub is really stressed and needs resuscitation, they might just tell you to clamp and cut it.
We also want to send the placenta to find out why Katie's gone into preterm labour. Was it because of choreo, which is one of the most common causes? Was it because of abruption? Or any other pathology that might help us manage her future pregnancies?
And that wraps up our episode for today. We've covered the clinical workup of preterm labour, including history, exam, and diagnostic tests, including the fetal fibronectin, actin pardus, Pardusure, and transvaginal cervical length. We've also covered the principles of management: steroid loading, tocolysis, antibiotics, corticosteroids, and magnesium sulphate. Keep an eye out for our episode summary on Instagram, and join us next week for our final episode on preterm birth, where we discuss how we can prevent preterm birth.